Hello, my name is Ali Mohammed. Welcome to my Bio 434 term paper presentation. Today I'll be discussing one of the most um, persistent and deadly pathogens in the human history, Plasmodium falciparum, the primary cause of severe malaria. We will look at its life cycle, the pathology of the disease, and the urgent race between drug resistant and the new vaccine technology. Um, to understand why this microbe is so important, we have to look at the numbers. Malaria is still a massive global health crisis. According to the World Health Organization in 2023 alone, there was an estimated of 263 million cases and nearly 600,000 deaths. While there are severe species of malaria, Plasmodium falciparum is the one responsible for the vast majority of fatal infections. Tragically, this burden falls heaviest on the vulnerable children under 5 years old in sub-Saharan Africa, account for 75% of all malaria's deaths. Um, so what causes this disease? The etiology is a protozoan parasite called Plasmodium falciparum. It belongs to the phylum Apicomplexa. It's transmitted to human exclusively through the bite of an infected female Anopheles mosquito, which requires a blood meal to nurture her eggs. Once introduced into the human body, the parasite targets the liver first, and then the red blood cells, which is where the clinical disease actually begins. Um, for the life cycle, it has a complex life cycle involving two hosts. First, the mosquito injects the sporozoites into the skin. These travel to the liver and infect the hepatocytes, multiplying silently. They then burst out as merozoites, and they enter the bloodstream. This begins the blood stage. The parasite invade red blood cells, maturing from rings to trapezoids to schizones. Eventually, they rupture the red blood cell, releasing more parasites um, to infect new cells. This cycle of rupture is what causes the classical wave of fever. Finally, some parasites become gametocytes, which are picked up by another mosquito to complete the loop. So, what makes Falciparum unique and dangerous compared to other malaria types? Its pathology. Infected red blood cells express sticky proteins such as PFEMP1 on their surface. This causes a cytoadherence, where the blood cells stick to the lining of the small blood vessels in the organs like the brain and lungs. And this blockage stops the blood flow, leading to tissue hypoxia, which is basically a lack of oxygen, and intense inflammations. This mechanism is the direct cause of severe complications like cerebral malaria and multi-organ failure. Um, so clinically, we distinguish between symptoms, what the patients feel, and signs. And that's what the doctors are measuring and looking for. Symptoms often starts like flu, cyclic fever, shaking chills, severe headaches, and fatigue. Patient may also report nausea and abdominal pain, but signs, that's the medical stuff that can be observed, including severe anemia due to the distraction of the blood cells, jaundice from liver involvement, and enlarged spleen. In severe cases, objective signs include confusion, seizure, or comma, indicating that the brain is also involved. For treatment, we must first confirm the diagnosis. Global gold standard remains microscopy. Clinicians look at gamma-stained blood smears to visually identify the parasite and count the density. However, in many remote areas, rapid diagnostic tests, RDTs, um, are used as well. These look like the COVID test. They detect specific parasite antigens like HRP2. And the final approach is PCR tests. They use to research or complex research for complex cases. They're highly sensitive but take longer process time. Uh, Once diagnosed, speed is the key. The standard first-line treatment for the uncomplicated malaria is artemisinin-based combination therapy, or ACT. This combines a fast-acting artemisinin derivative to kill the majority of the parasite quickly, with the longer-lasting partner drug to wipe out the survivors. For patients with the severe malaria who cannot swallow pills, the WHO recommended intravenous artesunate to rapidly clear the infection. However, our best treatment is under threat. We're seeing growing evidence of artemisinin resistant. This is genetically linked to mutations in the parasite's K13 gene. While this resistance began in Southeast Asia, it's now moving into Africa. For example, a primary research study in 2013 identified parasites in Ethiopia carrying these K13 mutations. They found that these parasites survive longer after treatment, leading to delayed clearance. If this resistance spreads widely, we risk losing our primary defense against the disease. Fortunately, there's good news in the form of new technology. For decades, we didn't have any vaccine for malaria, but now we have two. The first one is RTSS, but recently we have a new one called R21 matrix M. It has shown superior results. In a major phase 3 clinical trial published in 2024, the R21 vaccine demonstrated approximately 75% efficacy in preventing malaria in African children over 12 months period. This is a game changer and has recently been recommended by the WHO for wide use. Um, Looking to the future, vaccine alone aren't enough. We need a multiple pronged approach. So scientists are currently developing next generation drug that target different pathways to bypass the K12 resistancy. We're also increasing molecular surveillance to track where resistance is spreading in the real time. There is enough research into genetically modifying mosquitoes to stop them from carrying the parasites altogether. Um, so to summarize my presentation, the three key takeaways are Plasmodium remains the deadliest form of malaria due to its ability to cause sticky blood cells and organ failures. We're facing a critical challenge with the K12 mediated drug resistance, which is now being detected in East Africa, and the recent rollout of the R21 matrix M vaccine offers a powerful new tool that could save hundreds or thousands of lives. And those are my references. Thank you so much.